Welcome to Lesson 13 to 2026 Telehealth Services, CPT, Medicare, and Virtual Care Coding. In this lesson, we will explore the fundamentals of telehealth coding and the major services that medical coders need to understand for 2026. We will discuss synchronous audio, video, and audio-only services, virtual check-ins, remote evaluations, Medicare telehealth services, interprofessional consultations, and remote patient monitoring. We will also review important CPT and HCPCS code categories and highlight key 2026 Medicare updates. By the end of this lesson, you will be able to recognize the different types of telehealth services and understand the basic factors used to select the appropriate code. Let's begin with the fundamentals of telehealth services. Before we begin, please note that this training is for educational purposes only. Medical coding guidelines may change annually. Always verify your coding with the latest CPT, ICD-10CM, HCPCS Level 2 manuals, official coding guidelines, and payer-specific policies before assigning codes. Now let's begin with the fundamentals of telehealth. Telehealth refers to healthcare services delivered through telecommunications technology, allowing patients and healthcare professionals to communicate without being physically present in the same location. There are several important types of telehealth services. Synchronous services involve real-time interaction between the patient and provider, such as a live audio-video visit. Asynchronous services, also known as store and forward services, involve information being collected or submitted and reviewed by the healthcare professional at a later time. Remote patient monitoring, or RPM, involves the collection and management of patient health data through connected devices. Examples can include blood pressure, weight, glucose, or other physiologic measurements. Another important concept is that the patient and provider may be located in different places. The originating site refers to the patient's location at the time of the service, while the distant site refers to the location where the healthcare professional providing the service is located. For coding purposes, always identify the type of service first. This will help guide you toward the appropriate code family and applicable payer requirements. Now let's look at the major categories of telehealth services. Telehealth is not a single type of service. Different services use different technologies and have different coding requirements. First, synchronous audio-video services involve a live, two-way interaction between the patient and healthcare professional using audio and video. Second, synchronous audio-only services involve real-time communication using audio without video. Third, virtual check-ins are brief technology-based communications that may help determine whether the patient needs a more extensive service. Fourth, remote evaluation involves the provider reviewing recorded images or video submitted by the patient rather than conducting a live encounter. Fifth, an e-visit involves online, patient-initiated communication with the healthcare professional. Sixth, remote patient monitoring, or RPM, involves collecting and monitoring physiologic data from the patient, often through connected devices. Finally, interprofessional consultation involves communication between healthcare professionals regarding a patient's care rather than a direct patient-provider encounter. For coding, the key point is simple. Identify the type of telehealth service first. Then review the patient status, documentation, code requirements, and applicable Medicare or payer guidelines before selecting the code. Now let's look at EM level selection for telehealth services in 2026. A telehealth encounter does not automatically determine the EM level. The coder must apply the appropriate EM guidelines based on the service performed and the documentation. The level may be selected using medical decision-making, or MDM, or total time, when the applicable EM family allows time-based selection. We also need to determine whether the patient is new or established, select the correct EM code family, and make sure the documentation supports the service reported. Finally, always consider payer-specific telehealth requirements, because Medicare and commercial payers may have different coverage, billing, or telehealth policies. The key point to remember is, the technology used for the encounter does not automatically determine the EM level. The level must be supported by the applicable EM guidelines and documentation. Now let's look at the CPT telemedicine EM codes for synchronous audio-video services. For new patients, CPT codes 98,000 through 98,003 represent 4 levels of service, from straightforward to high medical decision-making. For established patients, CPT codes 98,004 through 98,007 are used, again ranging from straightforward through high medical decision-making. These codes are specifically designed for synchronous, real-time audio-video telemedicine (EM) services. However, there is an important point for medical coders. A CPT code does not automatically mean that Medicare will reimburse the service. The CPT code set and Medicare payment policy are separate considerations. Therefore, before reporting these codes, always verify the current payer-specific policy, including Medicare requirements. So, remember the key point. 98,000 through 98,007 are CPT telemedicine (EM) codes, but code selection and payer coverage must always be evaluated separately. Now let's discuss synchronous audio-only (EM) services. In the CPT code set, 98,008 through 98,011 are used for new patient audio-only (EM) services, ranging from straightforward to high medical decision-making. For established patients, 98,012 through 98,015 represent the corresponding levels, again from straightforward through high medical decision-making. These services involve real-time, two-way audio communication between the patient and the healthcare professional. However, there is an important Medicare consideration. These CPT codes should not automatically be reported as Medicare-paid telehealth (EM) codes. For Medicare claims, the coder must follow the current Medicare telehealth requirements and use the codes that Medicare recognizes and allows for the specific service. So, remember, first identify the type of service, then determine the patient status and appropriate level, and finally verify the payer's current coding and coverage rules. Now let's discuss the virtual check-in. CPT 98016 describes a brief, synchronous, technology-based communication service for an established patient. The service is patient-initiated and involves 5 to 10 minutes of medical discussion. The purpose is generally to determine whether the patient needs a more extensive evaluation or other service. An important point is that video is not required for this service. The communication can be performed using an appropriate technology-based method. Another key coding rule is that 98016 should not be reported with CPT 98,000 through 98,015 for the same service. For exam purposes, remember the core concepts: 98,016, established patient, patient-initiated, brief communication, 5 to 10 minutes, and virtual check-in. Always verify the current CPT and payer-specific guidelines before reporting the code. Now let's look at two services that are different from a live telehealth visit: remote evaluation and online digital (EM) services, also commonly called e-visits. G2010 is used for the remote evaluation of recorded video or images submitted by an established patient. This is a store and forward type of service, meaning the information is reviewed remotely rather than through a live, real-time encounter. Another category is online digital (EM) services, codes 99,421 through 99,423. These services involve online communication between an established patient and the healthcare professional, with the service measured using cumulative time over a period of up to 7 days, according to the applicable coding guidelines. The key distinction is simple: recorded information is not the same as a live telehealth visit. As coders, we should first identify how the communication occurred, determine the patient's status, review the applicable time or service requirements, and then select the appropriate code. Always verify the current CPT, HCPCS, Medicare, and payer-specific guidelines before reporting these services. Now let's look at Medicare telehealth consultation codes. For initial or emergency department and inpatient consultation services, Medicare uses HCPCS codes G0425, G0426, and G0427, based on the required time. For follow-up inpatient consultation services, the codes are G0406, G0407, and G0408. For critical care consultation services, G0508 is used for the initial service, while G0509 is used for a subsequent service. The important point for coders is to keep these Medicare HCPCS codes separate from the CPT 98,000 through 98,015 telemedicine (EM) family. Always identify the payer, type of service, setting, documentation, and applicable current Medicare guidelines before assigning the final code. Interprofessional consultation is a provider-to-provider service. In this situation, the treating healthcare provider requests the opinion or treatment advice of another qualified healthcare professional. The consultant reviews the patient's clinical information and provides an assessment, recommendations, or management advice. The communication may take place by telephone or through internet-based communication. An important point for coders is that the patient does not necessarily have direct contact with the consulting provider. So, always distinguish between a patient-to-provider telehealth encounter and a provider-to-provider interprofessional consultation. Before selecting a code, identify who participated in the service, why the consultation was requested, how the communication occurred, and what was documented. Remember, correct coding starts with identifying the type and purpose of the service. Remote Patient Monitoring, or RPM, is a telehealth service that allows healthcare professionals to monitor a patient's physiologic data remotely. RPM generally involves three important components. First is device setup and patient education, where the patient is instructed on how to use the monitoring equipment. Second is the collection and transmission of physiologic data from a connected device. Examples include blood pressure, weight, oxygen saturation, glucose levels, and other physiologic measurements. Third is treatment management, which involves the healthcare professional reviewing the information and managing the patient's care as appropriate. For coding, remember that RPM is more than simply providing a device. The coder should identify the specific service performed, review the documentation, and verify the current CPT, HCPCS, Medicare, and payer-specific requirements before assigning a code. The key point is, identify the RPM component being reported and make sure the documentation supports the service. Now let's look at the 2026 updates related to remote patient monitoring and digital medicine. Remote monitoring continues to evolve, so coders should not rely on older 2025 code descriptions or billing information when coding 2026 services. For 2026, always start with the current 2026 CPT code set and review the current code descriptor. Then check the applicable Medicare or payer-specific coverage and billing requirements. CMS has also addressed payment methodology for certain remote monitoring services in the Site 2026 Physician Fee Schedule Final Rule. This makes it especially important to distinguish coding information from payment policy. A simple way to remember this is 2026 code set right pointing arrow 2026 descriptor right pointing arrow 2026 payer rule. The key message for coders is to use the correct year and verify current guidance before assigning an RPM or digital medicine code. Now let's review the major Medicare telehealth updates for 2026. CMS finalized a streamlined process for adding services to the Medicare telehealth services list. Beginning in 2026, CMS removed the distinction between provisional and permanent telehealth services and simplified its review process. Another important change is the permanent removal of frequency limitations for subsequent inpatient visits, subsequent nursing facility visits, and critical care consultations. This means these services are no longer subject to the previous Medicare telehealth frequency limits, effective January 1, 2026. CMS also finalized a permanent policy allowing virtual direct supervision through real-time audio-video communication for applicable services, with certain exclusions. CMS. For medical coders, the key point is that these are Medicare policy changes, not simply changes to Captain code selection. Always verify the current CMS telehealth list, Medicare guidance, documentation requirements, and payer-specific policies before reporting a service. Remember, 2026 Medicare telehealth rules must be checked against current CMS guidance, not older 2025 materials. Let's look at two practical CPC coding scenarios. Example 1. A Medicare patient receives an EM service through synchronous audio-video communication. The question is, should the coder automatically select CPT 98001? The answer is no. Although 98001 is a Captain telemedicine code, the presence of a telehealth encounter does not automatically determine the code for a Medicare claim. The coder must first check the current Medicare telehealth requirements and the applicable EM coding rules. Example 2. An established patient sends recorded images to the provider for evaluation. In this situation, G2010 may apply when all applicable Medicare requirements are satisfied. The important lesson is, do not select a code based only on the technology used. First identify the type of service, patient status, documentation, payer requirements, and applicable code guidelines. Remember, service type plus documentation plus payer rules leads to accurate coding. Let's summarize the key points from our 2026 telehealth services lesson. First, identify the type of service. Determine whether the encounter is audio-video, audio only, a virtual check-in, remote evaluation, e-visit, or remote patient monitoring. Second, identify the patient status, whether the patient is new or established, when that distinction applies. Third, identify the payer. Medicare, commercial insurers, and other payers may have different coding and coverage requirements. Fourth, select the appropriate code family, such as CPT or HCPCS, based on the service and applicable guidelines. Fifth, review the documentation. Depending on the service, this may include medical decision-making, time, communication details, or other required elements. Finally, because this is a 2026 lesson, always verify the current CMS guidance, CPT descriptors, Medicare requirements, and payer-specific policies. The most important CPC tip to remember is, never choose a telehealth code based on technology alone. Identify the service first, verify the documentation and payer requirements, and then select the appropriate code. That completes our lesson on 2026 telehealth services.